In this episode of Questions People Ask, we'll take a deep, nuanced dive into alpha-gal syndrome with a lot of the content really intended for healthcare providers and those who are actively managing patients with AGS. As always, my thoughts and opinions are intended to inform and educate, but not to serve as direct medical advice. Before we get into the clinical management of patients with AGS, let's begin with a bit of history. The whole alpha-gal syndrome story really began in the oncology field. This would have been the mid-2000s, and I was an allergy and immunology fellow at the University of Virginia. I was a member of Dr. Thomas Platts-Mills' lab, and he identified alpha-gal IgE. That discovery came as I was joining his group. They had just unraveled the observation that cancer patients being treated with a monoclonal therapeutic called cetuximab were having allergic reactions to the medication, and it was occurring on the first infusion. This presentation, it turns out, would pique the interest of almost any allergist. That's because it means the allergic response from the immune system is present before the medication is given. Why would a patient react to a cancer medicine that they've never received before? These are not trivial medications, so it's not as though there was an accidental exposure prior. No, in this scenario, the IgE response was already being made by the patient's immune system, and as we now know, it was directed against alpha-gal. Cetuximab, as it turns out, is made in a mouse cell line, and those cells add alpha-gal as part of a post-translational glycosylation step. While it's entirely likely that the patients who reacted to cetuximab had tick bites that caused them to develop alpha-gal IgE, we don't actually know that because the tick connection came several years later, and tragically, these patients were no longer living. The reactions to cetuximab occurred quickly, 5 to 15 minutes into the IV infusion. The reactions were consistent. Each dose of cetuximab produced a reaction, and patients had to undergo desensitization each time in order to safely receive it in instances where that was necessary. And the reactions to cetuximab were regional. This was an allergy that largely afflicted the South. Oncologists outside of the Southeast were largely unaware of this issue. They just were not seeing it in their patients. When I joined Dr. Platts-Mills' group, my focus became the apparent reactions to red meat that we suspected and later demonstrated were due to that same alpha-gal IgE response. Only in these patients, the reactions were delayed, inconsistent, but equally regional. So the story from patients was that they might be allergic to beef, but they would say it's weird. The reactions didn't happen right away. They had often described a long delay between most frequently eating dinner and then the onset of symptoms often would wake them from sleep. At first, we even thought about thinking of alpha-gal allergy as kind of midnight anaphylaxis, if you will. So the reactions were delayed. Patients would also say that the reactions didn't happen every time. There was an inconsistency to the reactions. And sometimes they would say it's really bad, but on other occasions, they would really just complain of some itching, most prominently palms and soles. And a few of the patients said, I'm so suspicious of beef, I basically stopped eating it and was eating more pork. But then I started reacting to pork and have been eating more lamb, and I think I'm reacting to lamb as well. What we've come to understand over the years is that many of these patients, though, don't present with the typical story. They're unlikely to tell you as a provider, hey, I'm allergic to beef. In fact, there were probably only a dozen or so patients who initially gave us some semblance of that story. Many of the people that we ended up diagnosing, and still is true today, they have no sense that it's red meat that's causing their reactions. They would have otherwise been perhaps considered idiopathic anaphylaxis or idiopathic urticaria. So just because the story is outlined here, don't think that they will always come in saying that they're allergic to beef, pork, lamb, etc. That's not really the case. So when you as a provider begin to potentially suspect or at least want to rule out that maybe someone has alpha-gal allergy, this is the test that we recommend an alpha gal specific IgE blood test. It can be available as a panel, just depends on the lab service that is in your area. It certainly doesn't have to be ordered that way, but we do see patients who often have results for IgE to beef, IgE to pork, IgE to lamb, as well as IgE to alpha gal. These days, probably not unreasonable to order a total IgE with a forward thinking nod to potentially starting omalizumab or Xolair under a food allergy indication. We'll talk about that a bit later, but I think it's reasonable to include a total IgE in the blood tests as well. But the alpha gal IgE blood test, it's commonly considered a component based test within some of these panels, but it certainly should be orderable throughout the United States and globally as well. I will say it's not a great test if there is no clinical suspicion. It's a bad screening test, particularly so if you live in an area where Lone Star ticks are prevalent, or if there's not much clinical suspicion and patients complaining of maybe fatigue or joint pain. I don't think alpha gal IgE is the test that I would go to right away. The reason for that is that there's a high false positive rate in many places in the US where Lone Star ticks are prevalent. For example, when we've done a case control study, almost 30% of our control patients who eat beef, pork, lamb, etc., totally fine, have no symptoms of allergy whatsoever. 30% of those participants test positive. And there would be no reason to ask them to take red meat out of their diet or avoid dairy. So it's a really poor screening test. It should really be used when there is an index of clinical suspicion. If you do test for alpha gal IgE, the testing pattern that we typically see is shown here. So you don't need all these other surrogate tests, but if they are run, this is what it would look like. You can see the alpha gal IgE being positive at the far left, and on the y-axis is the specific IgE response. This was published in 2009 from the original report of alpha gal syndrome. And then beef, pork, and lamb show up positive. Chicken, turkey, and fish are typically negative, unless, of course, the patient is separately allergic to those. But notably, cat and dog would show up positive for someone who has alpha gal IgE. And that's because these tests are mammalian. So there's going to be a small amount of alpha gal on any of the tests that have a mammal origin. Just because someone tests positive to cat and dog in this scenario does not mean that they have to avoid cats or dogs or have to get rid of their household pets. That's not at all true. In fact, these patients typically are not allergic to cat or dog dander. And this would be evidenced here by the row between cat and dog, which is FeLD1. There were a few patients who were positive for FeLD1 IgE in that original study, and that is the main cat allergen. But the cat and dog being positive as tests for a patient that has alpha gal allergy is just in keeping with the fact that they react to mammalian testing. Now, we don't typically do skin testing for alpha gal allergy at this point because the skin tests, it turns out, don't show up very well. That is the skin prick test. The under the skin or the intradermal testing, which we don't typically recommend for food allergens, can be positive. And we did use this initially before the alpha gal IgE blood test was ubiquitous. And now that it is, there's really not much of a need to do skin testing. I will say that on rare occasions, I have performed skin testing with cetuximab. That was the cancer medication mentioned a few slides ago. That medicine has plenty of alpha gal on it, perhaps even more than is present in the beef, pork, lamb allergen extracts that are used for skin testing shown here. So if you're really suspicious, someone has tested negative for alpha gal IgE, and you want to do skin testing, maybe to document because they've still had ongoing reactions clinically, cetuximab could be used in that scenario. I typically begin with cetuximab diluted 1 to 1,000 and do prick testing, and you just titrate the dilution from there. I have done intradermal testing to cetuximab, but again, that's very rare. So, what do the alpha gal syndrome reactions look like? Well, there's a couple of different forms. The one we'll call original, these are patients who have signs or symptoms from fatty red meat ingestion. It could be lean red meat too, but typically the fattier the meat, the more likely they are to develop symptoms. Many of these patients are fine with dairy. They can eat cheese pizza, they can have ice cream, no issues. Some of them certainly have to remove dairy from their diet as well. These folks talk about itching, swelling, angioedema, hives, diarrhea, low blood pressure, chest tightness, difficulty breathing. They have anaphylaxis. The symptoms are typically delayed 3 to 6 hours after the exposure. The second version of reactions tends to look like folks who have gastrointestinal only symptoms. These are not the people who would end up in an allergist office. They would be much more likely to go see their GI specialist because they are truly getting crampy abdominal pain. The reactions can have nausea, vomiting, diarrhea. They're typically not as delayed, so maybe more on the 2 hour spectrum there. And they can often be bothered by dairy, particularly fatty dairy as well. Thinking a little bit more about the GI presentation, Dr. Sarah McGill, who's at UNC as well, she and some of her colleagues have really thought hard about isolated gastrointestinal distress as a presentation of alpha gal allergy. These are the high points from a 2021 publication where almost 90% of them reported abdominal pain, three-quarters reported nausea, diarrhea almost 70%, and it was mainly episodic as opposed to chronic. And those were the most common symptoms. In fact, 9 of the patients in their series met criteria for diarrhea predominant IBS. They often reported awakening at night with GI distress, and in keeping with what we've talked about already, did not report a response to every exposure. So that inconsistency shows up even in the GI predominant patients. Interestingly, none of the patients related their GI symptoms to mammalian meat ingestion before diagnosis. About three-quarters of them did recall a tick bite. But these patients are not going to come to you, at least in my experience, and say, I think I have GI predominant AGS. They're going to be frustrated by their episodic or acute recurrent GI symptoms, and you may have to elicit whether they in fact eat red meat, how frequently, and then see if they turn up positive for alpha gal IgE. The median time from symptom onset to diagnosis was 21 months in this case series. There has now been enough awareness of the alpha gal syndrome GI presentation to where the AGA has issued a clinical practice update on AGS for the GI clinician, and this is available online for those who are interested. But my point is there's increasing awareness, particularly within some of the GI specialist circles, that AGS can really mimic IBS for some patients, and that in specific locations, we really need to be paying attention to alpha gal syndrome as a GI presentation and diagnosis. Continuing on with the alpha gal syndrome phenotypes and clinical presentation, a third version of this is patients who are basically allergic to all things that are mammal. And this can include fumes, importantly. There's probably an element of mast cell activation syndrome in these folks as well. I would consider oral antihistamine up to 4 times daily dosing. And we'll get back to that later on. Also, adding gastrochrome, which is cromolyn sodium, if there is a GI portion to some of their symptoms. And we use compounded ketotifen for these folks as well if needed. And in later slides, I will give you the dosing for some of those medications as well. A fourth presentation can be folks who have had basically one bad reaction and have no ongoing signs or symptoms despite continued meat consumption. Perhaps their one reaction was significant enough, or they got in front of the right provider and someone drew an alpha gal IgE and that came back positive. And now we're left trying to decide, do we ask them to go back to a red meat free diet, even though in the subsequent days or weeks, perhaps from the reaction before the blood test results, before they end up in our clinic, they've been safely or successfully eating beef, pork, lamb, etc., and now don't really want to give that back up. And this becomes shared decision making in my mind. These folks could, in fact, have additional reactions. We'll talk about some of the cofactors later on. And many times it becomes a question of, how do we create the lowest risk for you, but yet still try to have some exposure if that's desired. Some of these folks are just happy to know the answer and they'll continue to safely avoid red meat, no questions asked. But others really want to be able to put red meat back in their diet. So it becomes a bit of a clinical discussion. One of the things I hear not uncommonly is that someone has an alpha gal IgE that is positive. Maybe their symptoms are joint pain and itching, maybe some brain fog, and they've removed red meat as well as dairy and any other mammal exposure that they can think of, but their symptoms are not improved. And I think it's important to remember that, again, this is not a great screening test. So there's going to be people who will test positive, and this will not be the correct diagnosis. So in my mind, it is worth checking back in with these patients after we make the diagnosis, because we want to know, are they better? Are they having fewer reactions? Are their symptoms improved? If not, then we need to understand that it may not be the correct diagnosis for them. And the reasons that it could be a false positive, as I talked about, number one, there's a high rate of testing positive in non-affected individuals, especially in tick-heavy areas. So, number two, do the symptoms correlate with times of eating red meat? While this reaction may not happen every time, if someone is an infrequent consumer of red meat but yet has symptoms every day, then this, again, may not be the correct diagnosis. And thirdly, perhaps most importantly, does avoiding red meat, and this could potentially include dairy as well, lead to improvement? If it doesn't, then the first thing we typically do is, before we abandon the AGS diagnosis for that patient, is to ask, okay, let's push harder on your avoidance diet. Let's tighten it down. Let's take away dairy. Let's take away gelatin, anything that might be mammal based or even contaminated, and go as alpha gal free a diet as possible. Really play that card and see if your symptoms improve. If they don't, and you've done everything from an avoidance standpoint, then AGS is probably not the correct diagnosis, and we need to move on and do some additional evaluation to find out what's really underlying someone's symptoms. I really do consider alpha gal syndrome a syndrome, not just an allergy. And it's basically been renamed that, or AGS, to reflect the relevant exposures extend well beyond mammalian meats. So I mentioned dairy already, and this is the typical dairy you think about: cheese, butter, yogurt, cow's milk, goat's milk, etc. Gelatin can also be a player in alpha gal syndrome. Medications, which include capsules or vaccines or tissue implants, can have mammal based components. There is gelatin primary in foods such as jello, candy, marshmallows, etc. It can be added to foods in meats or sauces, even as a potential clarifying agent in some wines. Importantly, the mammal based medication heparin comes up a fair amount. Heparin is cow lung and pork intestine, and it is basically quantitated and standardized based on its anticoagulation properties, not on its alpha gal content. So there is a fair amount of lot to lot variability in heparin, but it is most definitely a mammal based medication. There are other medications that are produced in mammalian cell lines. As I mentioned earlier, the entire story around cetuximab and the murine cell line that was used to produce it led to extensive glycosylation with alpha gal. Medications may contain alpha gal sourced derivatives. Then there's carrageenan, which has alpha gal, but it's a plant based ingredient. It's a thickener that's often used in various foods. Notably, each of these that has an asterisk is something that indicates an unlabeled allergen exposure. So if you have AGS and you're trying to do your due diligence to avoid alpha gal in all its forms, you can see that those ones that are indicated have no labeling to tell you that the allergen is potentially there. So truly the lack of labeling is a really important issue at the moment for folks that have alpha gal syndrome, and particularly for those who are quite sensitive. What to avoid eating? Well, the avoidance diet obviously primarily includes mammalian meat, particularly fatty cuts. Ice cream, because of the high fat content, is often something, even though that it's dairy, that people tend to have to avoid. And this is often individualized. And we have a discussion with patients about dairy. Typically, if it's okay, and dairy and cheese often are, we tend to leave it in their diet and use their symptoms to guide us. Gelatin and carrageenan are triggers for some people. I generally think that if someone is okay with dairy and cheese and ice cream, then the alpha gal exposure in gelatin or carrageenan is usually not sufficient to trigger reactions, meaning they get more alpha gal exposure in the dairy that they're already tolerating. So we don't worry about pulling gelatin from their diet or putting it on their avoidance diet list, so to speak. Natural flavors is a buzz, a two-word buzz phrase that food manufacturers will put on labels, and it can mean mammal, but it does not always. I typically will tell patients if they have a cracker or some type of snack that they think they react to, and there's the phrase natural flavors in the ingredients list, it's probably worth a call to the manufacturer to try to understand, in that setting, does natural flavors mean mammalian exposure? People with AGS will often report that they are most likely to react to the following byproducts. Far and away, fat content with tallow, suet, and lard are the most frequently encountered in terms of reactions. Whey as well. Vitamin D3, it's usually made from lanolin unless it's vegan. Glycerin, when it's derived from mammals, certainly some glycerin is plant based. Usually it's not labeled very well. It's also worth noting for patients that in the US, the term vegan is not regulated by the FDA, and there's no guarantee that a product is mammal free. However, vegan certified products are generally considered to be safer. It turns out that there are some reoccurring themes in alpha gal syndrome. And you've already heard me talk about fat content. More fat equals more symptoms. We think what happens is that fat basically protects the alpha gal sugar. So fat can get glycosylated, and that would be what we refer to as a glycolipid. And lipids form spheres, basically micelles, and that's how they get absorbed. So fat is specifically trafficked across the intestinal brush border and ends up in the lymphatic system entering the bloodstream through the thoracic duct in our neck. This whole process takes several hours, 3 to 4 hours generally. And probably in the sphere shape, the alpha gal sugars get protected from digestion. And then when fat gets trafficked into the bloodstream, it eventually opens up, so to speak, and the alpha gal epitope is then available for binding to IgE. So, consistently, we've heard from patients and even seen this in food challenges that the fattier the meat, the, the more likely they are to have symptoms and the more likely they are to have severe symptoms. The dose matters. So, unlike some of the more traditional food allergens, in this scenario, a small exposure often only leads to a minor amount of symptoms. Sometimes people can even tolerate a small exposure with no symptoms. But the larger the dose, the more likely they are to have symptoms as well. Cofactors, particularly exercise, exertion, and alcohol, are tremendously important when it comes to triggering or facilitating reactions in the setting of alpha gal exposure. So you're not going to react just to running on the treadmill. You have to have that alpha gal exposure. Having the presence of a cofactor alone without the alpha gal exposure does not create the risk for reaction. So these facilitate reactions, but in and of themselves, exercise, exertion, alcohol do not pose risk in the allergy setting for patients with AGS. The fourth thing on the list, recent tick bites. Fresh set of tick bites can increase the alpha gal IgE response from the immune system for patients. And the rising IgE seems to be associated with an increased sensitivity, meaning someone may be absolutely able to eat cheese pizza, but if they get fresh tick bites, they may well end up reacting to the dairy exposure in the cheese. And the good news is we then ask them, step away from dairy for a period of time. But ultimately, after a few weeks, these patients can typically resume eating what they were prior to the tick bites. It's just that the recent tick bites really seem to make people more sensitive. And then there's the inconsistency again. The fifth thing would be that inconsistent nature of reactions in alpha gal syndrome. I think it's worth a moment of discussion about the similarities between alpha gal syndrome and what has been termed pork cat syndrome. And the reason I think it's worthwhile is these two food allergy related diagnoses are very similar to one another and have a fair amount of overlap. So if someone seems to have alpha gal syndrome but tests negative, it's probably worth thinking about pork cat syndrome. And we've talked a lot about alpha gal syndrome. So on the left, obviously they react to mammalian meat. They can react to dairy. We talked about the specific test. Typically, their beef IgE is less than their alpha gal IgE, but beef tends to be greater than pork or lamb IgE. In pork cat or pork dog syndrome, the primary allergy is to cat serum albumin. It could be to dog serum albumin, and typically the pet exposure at home is the primary driver of whether it's cat or dog serum albumin as the allergen. Cat serum albumin is FeLD2, and the specific IgE test or request is listed there, RE220. For patients with pork cat syndrome, their pork IgE is greater than their beef IgE. So in some instances, this is where the panel that gets ordered not uncommonly with alpha gal IgE that includes beef and pork can really be helpful, because if the alpha gal IgE is undetectable and the pork IgE is higher than beef IgE in that same panel, you may be looking at a patient who has pork cat syndrome. And these patients react to pork, especially that which is cooked to a fairly lower temperature. So, higher thermal heating of pork meat tends to denature the cross reactivity such that they don't tend to react to well cooked pork. There does seem to be some variability in terms of reactivity to beef. In our hands, about 50% of the patients who have pork cat syndrome will also react to beef. And then of those who react to beef, about a quarter of those will also have trouble with dairy. So you can appreciate that there's a fair amount of overlap clinically with what patients might be telling you that they are reacting to between AGS and pork cat syndrome. The other part of this is that pork cat syndrome, they tend to react more quickly. So it's not that 3 to 6 hour delay. It tends to be more in the 30-minute to 2 hour portion, but it can equally be inconsistent, similar to AGS. So, avoidance of red meat can be just the beginning. And this is in keeping with labeling alpha gal allergy as a syndrome. It turns out that products from cows and pigs in particular find their way into numerous everyday products. And it's certainly not to say that someone with AGS can't play tennis because tennis racket strings may contain beef derived products. It's more just to make the point that alpha gal syndrome can go well beyond simply avoiding red meat. And so there are times when I am still surprised at what patients will react to. And I tend to believe them because it turns out that these mammal products are in so much of our everyday items. Clinically, the management of AGS is complicated by the appearance of so many of these mammalian sourced or derived ingredients in our medications and even bioprosthetic implants. So, one of the exposures that has come up over and over again is that of pancreatic enzymes. These are truly derived from typically porcine pancreatic enzymes, but there can be other mammalian sources as well. You can skin test to multiple different brands or doses or strengths of the various pancreatic enzymes and then try to pick the one that creates the least reactivity for the patient. That was what was done in this publication here. The patient was able to tolerate one of the pancreatic enzymes. I don't know that this is established, but in scenarios where you really need someone on a pancreatic enzyme, skin testing to several different varieties may provide the best approach to try to find the one that's tolerated. As I mentioned, bioprosthetic heart valves contain alpha gal, whether they are derived from cows or pigs. It's not fully clear how deep the implications are. We definitely have seen reports of patients who react initially at the time the valve is placed. I will comment that that can be difficult to truly sort out because heparin, which is also mammal derived, is typically used in high quantities at the time these valves are placed. So whether someone reacts to the valve or to the heparin can be a challenge to figure out. But also pericardial patches can be mammal derived and could be the source of a reaction as well. One of the questions that we're wrestling with is whether there could be premature valve failure due to perhaps destruction of the valve from a pro inflammatory IgE antibody response that is recognizing alpha gal present on the surface of those valves or patches. And maybe that is leading to an inflammatory state that perhaps could calcify or make the valve stiffer and lead to destruction. We do hope to have some answers as it relates to bioprosthetic heart valves due to a collaboration with Dr. Joe Turek's group at Duke University, where they are following patients who've had these valves placed longitudinally and assessing for whether the presence of alpha gal IgE may predict those who go on to develop premature valve failure. So hopefully more coming for that portion of the story soon. I mentioned heparin, and it has certainly been associated with anaphylaxis, well described in some patients with AGS. Interestingly, heparin can be tolerated by others. My sense is this is because it's not standardized by any stretch for the alpha gal content, but it is standardized instead for its anticoagulant properties. And the dose of it may be critical. There may even be some lot to lot variation. Because of this, I'm not sure that skin testing to heparin is necessarily helpful, but we tend to try to make folks aware and perhaps add some antihistamines ahead, maybe even some oral corticosteroids. But in the end, obviously, heparin creates many advantages because it is reversible. And therefore, we often try to work with our surgical colleagues or proceduralists who need heparin and prefer to perform those procedures that are necessary through the use of heparin. In keeping with the cardiovascular portion of this, there has been an association in two studies between alpha gal IgE and atherosclerosis. So there is not fully an association between proven alpha gal syndrome, meaning patients who clinically react to red meat, and atherosclerosis. The studies that are out there create this association between the blood test positive and atherosclerosis. In this study, it was 118 subjects who presented with chest pain. They did not come in because they were reacting to foods. They came in with chest pain, they underwent cardiac catheterization, and even intravascular ultrasound. Alpha gal IgE was found to be positive in 26% of those, and the atheroma burden associated was stronger in patients less than 65 years of age. And the plaques in the sensitized group, meaning those who had alpha gal IgE, had features that were less stable based on the intravascular ultrasound. That study was followed up with this one from an Australian group where alpha gal IgE was associated with non calcified plaque, obstructive coronary artery disease, and ST elevation MI. So in this study, alpha gal IgE was measured in the serum of slightly over 1,000 patients who were referred for CT coronary angiography and 100 patients who came in with a STEMI. The authors looked at multiple different biomarkers and inflammatory mediators, and alpha gal sensitization was independently associated with non calcified plaque, obstructive CAD, and occurred at a higher frequency in patients with STEMI than those with stable or no coronary artery disease. It is not known what proportion of the cohort had experienced symptoms secondary to having alpha gal IgE from an allergy standpoint, meaning they don't know how many of them truly had a red meat allergy and were having ongoing symptoms. So it's not really an association with clinical AGS and atherosclerosis. It certainly raises the question, and we need more studies related to this about the possible link between AGS and atherosclerosis. At the moment, I feel like patients who are practicing an AGS avoidance diet, meaning they're not having red meat, potentially limiting high fat dairy or dairy altogether, it's hard to imagine that we could ask them to do more for a heart healthy diet. But this question currently remains and is one that in my mind, is in need of additional data to help guide our understanding and clinical recommendations for AGS at this point as it relates to heart disease. Armor thyroid may be one of the more common medication questions that I get. It is truly derived from a natural preparation of pig thyroid glands. It certainly has caused folks to have itching or hives, and I would imagine more severe reactions as well. So it can be a tough one to tolerate for folks who are sensitive, and in many instances, we need to resort to a more synthetic version of thyroid for replacement in patients with AGS. Some of the general exposures that are important in the management of patients with AGS include vaccines that could contain gelatin or other mammalian byproducts. In the US, these most commonly and notably include MMR, and we suggest using the Priorix brand that was approved by ACIP and does not have gelatin. For Tdap, we tend to use Adacel, as the Boostrix brand appears to have alpha gal content based on our clinical experience. Influenza vaccination, generally these are alpha gal safe, except possibly Flucelvax and Flu Mist. I advise this to be reapproached every fall as these influenza vaccinations come to the clinics, and we generally tend to need to re-explore what ingredients are in each. But Flucelvax and Flu Mist have come up most recently as ones to avoid. For RSV, Abrisvo and Arexi are produced in Chinese hamster ovary cells. Some limited data and experience, but we suspect that these are alpha-gal safe. What's no longer in use in the US is Zostavax, but this could be in use elsewhere. And I would suggest avoiding Zostavax because it typically has gelatin in it if you have alpha-gal syndrome or patients with AGS. Antivenom, such as Crofab, certainly can have alpha gal, but I generally would say if someone wants to give you antivenom because of a bite or sting, I would take it and then deal with the potential allergic ramifications if they happen. But it certainly has been reported that antivenom can have alpha gal. So it would be reasonable to alert patients and any providers who were not aware of that prior to giving antivenom so that they could at least anticipate the possibility of an allergic response. Other general exposures that particularly relate to gelatin could include various hemostatic agents, absorbable gelatin sponge, gabapentin, a medication, has a very specific formulation of gelatin that has caused several patients to have reactions. And you can see the list goes on there. It's certainly worth mentioning outside of the US, gelatin based plasma expanders are common, and these can be causes of allergic reactions in patients with AGS. Occasionally, you get to the point with patients where they have continued reactivity despite a good avoidance diet and even a thorough avoidance diet. Maybe their symptoms are improved, so you do feel like you're on the right track. This is the correct diagnosis, but they just have some amount of continued reactivity. This table, which is adapted from a publication with very detailed diagnosis and management of AGS, provides a framework for things to think about beyond the typical avoidance diet. So we think about foods and remove dairy in all its forms, remove gelatin, carrageenan. Here's that natural flavoring again phrase, read labels for that. Environmentally, consider monthly washing of pets, avoid fumes of mammalian meats being cooked. Medication-wise, definitely consider starting folks on a daily oral or twice a day oral antihistamine. Switch to tablet formulations when possible or consider capsules. Personal care products, switching to natural toothpaste, avoiding creams or lotions with lanolin. this would at least be the start of a framework for trying to help patients who have continued reactivity despite an avoidance diet. One aspect of clinical care, which really hasn't gotten much attention, in my opinion, is that of the mental health burden of food allergy in general, but specifically of that of patients who have AGS. We know that adults are more likely to report experiencing anxiety around food allergy than pediatric patients. Adults are also more likely to estimate the severity of their allergies and panic attacks. Some of this is nuanced for AGS because it can be adult onset. It can come on at any point in time in life following the sensitizing tick bites. And so many of these folks have eaten beef or pork or lamb for years, decades, and had happily included them in their diet and are now forced with an avoidance diet, and they miss those foods. This can be very different than childhood food allergy, where there often is not a period of tolerance at all. And there can even be an aversion to, say, peanut or tree nut. And so those children or adolescents don't even want those foods in their diet. For AGS, that part can be very different. And patients often report constant fear and vigilance, feeling as though eating is no longer pleasurable or fun, and and eventually that the lack of labeling can be quite crippling. So even if we as providers aren't necessarily comfortable with prescribing SSRIs or other mental health related medications, at least we could potentially open the door to begin that discussion around the mental health burdens from alpha gal syndrome may be specific to AGS because, unlike more traditional food allergy, where there really isn't a period of tolerance, those patients often have an aversion to the food, whether it's peanut or tree nut. Differently, patients with AGS have often enjoyed including red meat in their diet for years or even decades, and they really miss that exposure. Some of these other burdens of alpha gal syndrome, which, in addition to the mental health burdens of food allergy and alpha gal syndrome, there are more specific burdens of alpha gal syndrome, which I believe Sarah Zhang has written the most compelling article about in recent memory, called Another Reason to Hate Ticks. In this, she profiles several patients with AGS whose lives and livelihoods and occupations have been upended by syndrome, and makes a compelling reason why we really need to address both the mental health side of this and the other life related burdens created by alpha gal syndrome. Some of the ongoing issues at the moment, as I see it, related to AGS include, most prominently, the inclusion of alpha gal IgE within certain tick borne disease or tick illness panels. Unfortunately, this type of testing doesn't seem to be driven by symptoms from patients, but more of a desire to cover all bases or perhaps not miss anything. Unfortunately, when it comes to alpha gal IgE, the high rate of sensitization or even false positive, if you will, amongst certain populations that have high tick exposure. In the US, that would be Lone Star ticks, but certainly other ticks worldwide, can create a false positive blood test. And then someone is asked now to be strict with an avoidance diet when their symptoms may not relate to alpha gal syndrome at all. So, again, we really prefer that alpha gal IgE testing be driven by a clinical suspicion for allergic related symptoms. Next, I would say is labeling. This is a real issue for patients that have AGS, particularly those who are quite sensitive to small exposures. There are certain inactive ingredients, in particular, magnesium stearate comes up a fair amount, where these inactive ingredients can be sourced from plants or fish or mammals, and labeling only has to indicate the presence of the inactive ingredient. It does not have to indicate the source. In fact, the source can change without any change in labeling. So nothing has to be declared, and patients could react to some exposure in one lot and then try that same cracker or medication again and not react just because the source of the inactive ingredient has changed. Another ingredient that bears mention when it comes to labeling is carrageenan. This is a thickener, but it is plant derived. It's a seaweed or an algae, and despite the lack of mammalian origin, does have alpha gal. Fortunately, most folks seem to be fine with carrageenan, but there certainly are people who react to it. And in those situations, it's worth reading labels and avoiding it. Lastly, for this slide would be fume or aerosolized based exposures that can lead to symptoms. Some patients with AGS who are highly sensitive will describe instances where they are walking past a grill or a restaurant and fumes that are airborne will trigger symptoms. Sometimes this can be fume based exposures that are occurring within restaurants, but there are other times when it is truly an outdoor issue. Interestingly, there are other examples of food allergens that become aerosolized, and fumes can lead to symptoms. This is most well known or best described for some seafood allergens, particularly in raw fish markets or in seafood restaurants where allergens are aerosolized and fume based reactions have been fairly well documented. So, even though this hasn't necessarily been shown for alpha gal, there certainly is a precedent within some of the other food allergy syndromes. So, that brings us to the next slide of questions people ask. The first of which is, does the level of alpha gal IgE correlate to the severity of reactions? In my clinical experience, there is not good correlation between these two. I think the reaction severity is often driven by the amount of allergen that's ingested, so the dose of meat, if you will, the fat content, like we've talked about. Also, was exercise involved? Was alcohol involved? The cofactors can be a big part of the severity of reactions as well. The other things that can come into play might be recent tick bites, which we'll talk about, but we have absolutely seen patients who have an alpha gal IgE of 80, but yet only report hives or maybe some mild itching or swelling, and other patients who may have an IgE of 2 to alpha gal who've had repeated episodes of anaphylaxis. So I don't see the correlation there. Secondly, does alpha gal IgE predict sensitivity to exposures? Again, we don't see that clinically. Secondly, does alpha gal IgE predict sensitivity to exposures? Again, we don't see that correlation. There are absolutely patients who report fairly solid histories of even fume based exposures leading to chest tightness and some of the anaphylaxis related episodes, and their specific IgE may be 2 or less. And others maybe have an alpha gal IgE of 50 but can tolerate dairy. So in in keeping with the lack of a correlation between severity and alpha gal IgE, we also see that sensitivity does not seem to be driven by the alpha gal specific IgE. I mean, it certainly can make it a challenge then when you're caring for patients, because you can't discount an alpha gal of 3. That patient may have anaphylaxis and may have a history of being very sensitive to small exposures. Whereas someone who has an alpha gal Ig of 73, you would think would be even more sensitive and have more severe reactions, and that just does not seem to be the case. Thirdly, what causes the alpha gal IgE to change? It really appears that tick bites are a big part of that alpha gal IgE kind of going up and down over time. It also increasingly seems as though bee and wasp stings can be part of a boost to the alpha gal IgE. And over time, the alpha gal specific IgE seems to wane. So, in getting at that fourth question, will this ever go away? Absolutely seems like for the majority of patients, this can totally resolve. The caveat is that additional tick bites or bee stings, maybe wasp stings, can keep the alpha gal IgE around and tend to act as almost like a booster to the allergy portion. And so if you get a fresh tick bite every 2 to 3 years, that may be enough to keep the allergy present. And many of these patients end up with AGS because they like to be outside or because their work takes them outside. So the idea that you get a tick bite even with excellent precautions once every couple years is not unreasonable, and that may be enough to keep the allergy around. So yes, it can go away, but functionally it doesn't resolve as frequently or for as many people as you might anticipate. So now we enter the tick portion of this episode. This slide I think is helpful because it, it draws attention to the adult female Lone Star tick, which is shown at the bottom left, and the characteristic white spot. It equally demonstrates that the adult male does not have the white spot, and therefore a Lone Star tick bite from an adult male can look like a sort of generic brown tick and not have that distinguishing marking. So people may think, well, I didn't have a Lone Star tick bite, but I find it a challenge to identify the adult male Lone Star ticks from several of the other tick species. So certainly something to keep in mind that the white spot is not ubiquitous, but is more characteristic of the adult females. The geographic range of Lone Star ticks in the US is shown here with the current approximate limit from 2022 all the way out to the portion in orange. There clearly was a prior historic limit that was then retracted, but the point in my mind is the expansion, the range of this tick is growing. So more and more folks are at risk, additional geographic areas, including now up into Maine, into the Great Lakes areas as well, and perhaps moving towards West Texas. Certainly, there are plenty of places in the central US, east of the Rockies, that are affected by Lone Star ticks and have plenty of folks with AGS now as well. This slide is really to make the point that the larval form of ticks can be incredibly small, very difficult to identify. And if you see 5 ticks, then you've done well. I first recognized 3 or 4, but they're the size of poppy seeds, and hence the moniker seed tick. But if you are someone who passes by a hatch of ticks where they can have 500 to 1,000 eggs laid at a time, you can easily get 50 to 100 bites from tiny little seed ticks, and in many instances those can be really difficult to distinguish from other bites. Seed tick bites, which are shown here, can be incredibly difficult to identify. You can end up with several hundred bites at once. They are incredibly itchy and they often don't latch well. They can be difficult to identify as ticks at all. And often you need a magnifying glass or a hand lens to be able to even tell that they are ticks. This early form of ticks has fewer legs, even. So they don't readily come to mind perhaps as an attached tick bite, but they can absolutely be part of the trigger for alpha gal syndrome to develop. To that point, I will often ask patients, have you been bitten by ticks, seed ticks, or chiggers? And in my mind, there's still some doubt or lack of evidence, perhaps is better said, around whether chiggers are part of this story. But I ask about ticks, seed ticks, and chigger bites in order to get folks to think beyond just an attached, embedded adult tick. I want them to think about these type of bites as well and begin to sort of broaden our recall of quote unquote tick bites. This graph shows the alpha gal IgE response to tick bites. This is actually not from Lone Star ticks, but a different form of amblyoma that is found in Japan. And this is data from one of the groups in Japan showing that the number of new tick bites going from 0 to greater than 4 is associated with an increase in the alpha gal IgE level. This slide depicts the sensitization and mechanism leading to symptoms in patients who have AGS. And while most of this slide remains accurate, we no longer think that the Lone Star tick has to bite a deer or a dog or a lower mammal to have a blood meal that contains alpha gal. That had been our initial thought, that the tick was basically picking up alpha gal from a blood meal that contained it because it was feeding on a mammal. And then it would sort of transfer that alpha gal remnant, if you will, into the bite when it attached to a human, and that would trigger the allergic response. It's pretty clear now from the work of Dr. Shahid Karim and others that the larval forms of ticks, which wouldn't have had a blood meal, can also be part of this AGS development and can trigger it. So they the ticks seem to have either alpha gal or some very similar epitope that they create in their own tick saliva, and they don't necessarily need that prior blood meal to drive the human immune response to alpha gal. So I think unfortunately it makes more people at risk because they can be bitten by the larval ticks and go on to develop AGS. But the rest of this slide, where the IgE develops and the lipid from the meal triggers the allergic response, we do think that most of that is probably still accurate. Interestingly, this fairly recent report indicated the levels of alpha gal within the salivary glands of Lone Star ticks fed on human blood can vary fairly greatly. And shown here, the males versus females on the left and right respectively can have a fair amount of alpha gal per tick, even if they have been fed on human blood through an artificial feeding system. So again, making the point that the prior blood meal definitely does not have to occur on a deer or a dog, but perhaps that prior blood meals in general can help drive some of this. And maybe the development of alpha gal in the tick saliva is simply due to some portion of the feeding process. So, certainly more to come there, but it does change the way that we envision the sensitization phase of AGS occurring. Even though that we have talked about ticks and alpha gal syndrome for several years, it really wasn't until 2023, so more recently, that a case control study established the relationship between tick bite and alpha gal syndrome. And in this study, we enrolled nearly 100 folks who had AGS and almost 200 controls who did not have alpha gal syndrome. So the data from the case control study are shown here, and they are that 88% of case participants, meaning they had a physician diagnosis of alpha gal syndrome and a positive alpha gal IgE. 88% of those reported tick bites in the prior year. Amongst controls, that number was only 47%. That produces an odds ratio of over 11 that the cases were more likely to self report a tick bite. Interestingly, if you look at the bottom red rectangle, those case patients, not only were they more likely to be bitten, they were also more likely to have lots of bites in the prior year. So 10 or more bites were reported by nearly 40% of the case patients, but only 17% of controls. I think the other important thing to mention related to this study is that amongst the controls who were enrolled from Chatham County, North Carolina, which is a mixed use and rural county south of the University of North Carolina in Chapel Hill, these controls, almost 30% of them had an alpha gal positive IgE. Keep in mind, to be a control in this study, you had to consume red meat, so it had to be in your diet, and you had to answer that it was causing you no known symptoms, that you consumed as much as you wanted, or at least weren't limited by any intolerance or allergic issues related to red meat consumption. So these were patients who were eating as much red meat as they wanted and yet still had an alpha gal IgE that was positive in 30% of them. So this is exactly why we don't like alpha gal IgE as a screening test, because you could easily pick up one of those 30% of participants who would have been enrolled as a control. It really has to be guided by the presence of clinical symptoms to make the testing more valid. The secondary analysis of some of the case control data demonstrated that family members seem to have an increased likelihood of food allergy, as well as an allergy to stinging or biting insects, and particularly the alpha gal allergy amongst case patients versus controls. What we don't know is whether this is evidence of a genetic predisposition that that some of those tendencies to create an IgE response to alpha gal would be familial or genetically inherited versus whether it's just that families might camp together or hike together and therefore be exposed perhaps to similar ticks. So we don't know if there could be some slight influence of specific tick populations in creating the IgE after a bite, and that could potentially play a role. So, more studies to come in terms of whether this apparent association from familial risk is due to genetics or just a shared tick related exposure. The other portion that came from the intrinsic risk factor analysis was that B antigen blood types. So if you're B or AB, you really may be less likely to develop alpha gal syndrome. It's definitely not something where you could say, well, if you're B or AB, that rules it out. That's certainly not the case. They just seem to be underrepresented. So maybe slightly protective in some manner against developing AGS. There has in the literature been an association of delayed onset diagnosis for alpha gal syndrome, meaning you might have symptoms for several years prior to diagnosis. And this appears to hold true, but we're getting better. So people who were diagnosed with AGS in the early stages, 2009 on, and sort of broken into quartiles here, you can see people diagnosed before 2011. It took on average 5.3 years for symptom onset to time of diagnosis. And now by 2019, we see that that's down to 28 days. So we definitely are making progress. In large part, I think that's increased awareness and education, both amongst patients and providers around AGS. Another interesting aspect around the time from onset to diagnosis data is that education levels seem somewhat predictive. So, high school graduates on average were about 4.4 years from symptom onset to diagnosis, whereas people who had completed at least some portion of graduate school were 1.4 years on average. Just something to keep in mind, perhaps amongst providers as we see patients, that those perhaps who are doing more research on their own related to their diagnoses may have a faster time to diagnosis. This brings up the next questions people ask slide. The first of which is, now that I have this, do all subsequent tick bites lead to increases in alpha gal IgE? It seems as though most tick bite will drive that alpha gal IgE after it starts. I don't think it's all. We've had a few instances where the alpha gal IgE doesn't rise in someone after tick bites, but invariably we think it is a really high percentage, maybe 95% of bites will push that alpha gal IgE up after the whole syndrome starts. What we don't know is whether the variables such as how many bites at once and how long the tick is attached, if those have different effects on the alpha gal IgE response subsequent to the syndrome developing. So more research is needed in that area. Secondly, is it only ticks that I must worry about? I've heard something about chiggers. This gets back to the seed tick photos and the idea that an attached adult tick is very identifiable, but some of these larval ticks can look like a chigger bite. You can have a single one, but you could have hundreds. They can be incredibly itchy, difficult to identify. I would say that in my mind, the scientific jury is still out around chigger bites, but I am certainly suspicious. I think to me, the gray area is that seed ticks, again, can really mimic chigger bites. Is it just Lone Star ticks? No. In the US, the Lone Star tick is our predominant tick associated with alpha gal syndrome. But worldwide, we know that there are plenty of other tick species associated with this because there are not necessarily Lone Star ticks, to my knowledge, outside of the US. And finally, I've been bitten by ticks for 60 years. Why have I now developed alpha gal syndrome? I think this is one of the most fascinating questions at the moment. The short answer is I don't know. I don't know that the field knows what the risk is that has changed. It's pretty clear that the ticks can develop or have the capacity to develop alpha gal or some version of it in their tick saliva. And that may be a relatively newer thing or characteristic that has evolved for some of these tick species in their salivary compartments. I don't think we have as much of the historic data. It also, it's pretty clear that alpha gal syndrome existed well before it was initially described in the late 2000s. There definitely are patients who have very well documented reactions and even blood test positive beef, pork, lamb panels prior to the description of alpha gal syndrome. So it clearly has existed for longer than it was described, but it also seems as though it's really increasing and it's still on the rise both in the US and globally. But the real risk about, why now, I think is an area of active investigation, and I don't know that it's truly been identified at the moment. So, in keeping with the question about just Lone Star ticks, this is the geographic range of species that are associated with reports of alpha gal syndrome cases. And you can appreciate that there are plenty of ticks beyond just Amblyomma americanum, which is the Lone Star tick, that have been associated with cases of alpha gal syndrome globally. So, thinking a little bit more US based about the geographic distribution of suspected AGS cases, this is an analysis of a serum from a central lab, Viracor urifins. And keep in mind that the data from this study is just IgE. So, it's not alpha gal syndrome diagnosed patients that were clinically interviewed. Like we only know about the positive blood test. So because there is this sensitization effect where people can test positive and not necessarily have clinical symptoms, we can't say that the data in the next slide is all people who have AGS. It's simply testing data. So that's the caveat. But when you look at it, these are the counties in dark blue where there are over 87 suspected cases based on blood test positive levels greater than zero point 0.1. And this is AGS cases per 1 million population per year in the testing that was performed from 2017 to 2022. And certainly some of those southeastern states that are dark blue were places that we anticipated would be a higher prevalence of alpha gal IgE, but there were some surprising things. 4% of all positive cases came out of Suffolk County, Long Island. There also were some dark blue counties in the Great Lakes area that we were not anticipating. So there's also a movement clearly to include some of the more central US counties as well. This may be, unfortunately, one of the last times we're able to get this kind of county level data just because the testing for alpha gal syndrome, AGS, alpha gal IgE has been decentralized. So it's no longer perhaps all going to flow through one primary lab, but be performed going forward by multiple different labs locally. So this was an opportunity to get a snapshot that we may not have again. So probably a really important snapshot. When we think about part of the data from that study is now to estimate based on the testing, perhaps how many cases of AGS are there in the US. Prior published data combined with the prior slide makes a total of roughly 110,000 suspect cases. And if you then do kind of the back of the napkin math and think about where are allergists, where are population centers, how many people are likely to go and get diagnosed officially versus how many people might just say, look, I get hives every time I eat beef or pork. I don't need a blood test to tell me that. So we're not going to have complete data. If in those estimations, it may be that as many as 450,000 people in the US alone have alpha gal syndrome. Despite those increasing numbers, unfortunately, healthcare provider knowledge is lacking. This is a study of 1,500 healthcare providers from 2022, where 42% of them who responded had not heard of AGS. And unfortunately, only 5% felt very confident in their ability to diagnose or manage patients with AGS. So hopefully, we can increase both awareness and knowledge about AGS. In addition to healthcare provider knowledge gaps, there's also a lack of understanding and awareness in the public. So, a survey from the fall of 2023 of slightly over 3,500 individuals, almost 70% had not heard of AGS or a red meat allergy associated with tick bites. Interestingly, only 58% even identified beef as a mammalian product. So definitely some education left to go there. And 51%, so when people had heard about AGS, they had heard about it from the news over the majority of folks, 51%, reported learning about AGS from the news. So the media is certainly a popular way to raise awareness, and it seems to be that that's one of the primary ways that that's occurring for alpha gal syndrome. So, finishing up in this last portion with some more clinical related slides and material, certain resources for management of patients with AGS. The first of which is omalizumab. The brand name is Xolair. This is a monoclonal antibody that binds IgE, binds free IgE to be specific. It was approved by the FDA for IgE mediated food allergy in February of 2024. Xolair certainly no stranger to allergists, as it has been approved for allergic asthma for almost 20 years. So, just with a recent food allergy diagnosis, I personally have over 60 patients who currently are on Xolair and they have alpha gal syndrome. It is mainly indicated to reduce reactivity and increase safety for accidental exposures. And folks, in my clinical experience, have done quite well on Xolair. One of the other resources that's really been transformative the past few years is Pill Clarity. This is the former outfit called Vegan Med, founded by Dr. Sachin Shah, who is a pharmacist, and his team of other pharmacists make their knowledge available for free for providers and the general public who need assistance finding products, whether it's personal products or medications that are available without animal derived ingredients. And they do an excellent job and have served as a great source of information for many of my patients and for others. The food app Fig has really been a great assistance to folks with alpha gal syndrome by identifying foods that may place them at risk for mammal based exposures. It's certainly reasonable to enlist the partnership of a dietitian or nutritionist in assistance with managing folks who have alpha gal syndrome. Particularly in my experience, if people need to avoid dairy and gelatin in addition to red meat, they may struggle to know what to eat, what to cook, what to buy, and having a dietitian or nutritionist involved can be a real help to the team taking care of some of these food allergic folks. In my practice, we refer to Julie Kennedy, and her website is shown there. She does a fair amount of virtual or telehealth related visits. So, things to do beyond avoidance. I mentioned oral antihistamines. It's certainly reasonable to consider 1 to 2 tablets of a long acting second generation oral antihistamine twice a day. Probably my favorites include Allegra and Xyzal. Allegra is not known to cross the blood brain barrier, and Xyzal seems to be well tolerated by folks. If there is concern about, magnesium stearate or other inactive ingredients that may have a mammal source to them, this is where the experts at Pill Clarity can really help us to know which versions, perhaps, of some of these medicines are safest for folks. You can also consider adding an H2 blocker. I really feel like this is the most helpful for folks who have GERD related symptoms. And we do a fair amount of Pepcid in various formulations as well. I'm a big fan of gastrochrome, which is cromolyn sodium, to address lingering GI symptoms. And I have a more to say about cromolyn in the next slide. Could also consider a short course of oral corticosteroids if people are having trouble with initial symptoms or getting their symptoms under control. I mentioned omalizumab, which is Xolair, and you may even feel like this could potentially be first line for people who have had profound anaphylaxis. Maybe they've ended up in the ICU, maybe they've been intubated, and safety is priority one. And in that scenario, Xolair may be the first thing that one chooses to turn to. One of the other medicines that I use on occasion is ketotifen. This has to be compounded, so it's certainly not as straightforward as some of the others, but can be a real help to folks with mast cell activation. And I'll have more to say about ketotifen in 2 slides. I mentioned gastrochrome. This is cromolyn sodium. It's the liquid cromolyn shown here in the picture. It's a mast cell stabilizer, but it's not well absorbed at all. So it's really a GI specific medicine. Comes in these kind of small ampules or vials. The dose is typically 100 milligrams per 5 ml, and it can be taken up to 4 times a day. Typically, folks will try to take a dose 20 or 30 minutes before a meal, and part of that can be used almost as prophylaxis when they're eating out to try to block symptoms from a meal where they're not 100% confident that the exposure is or the meal is clean. They're worried perhaps about a lingering exposure or cross contamination, that kind of thing. The other approach might be sometimes patients really struggle to get their diet fully clean, and sometimes people can be very sensitive, and so they may have small exposures that are still basically giving them GI symptoms, whether that's abdominal pain or cramping or diarrhea. And in those scenarios, we use gastrochrome almost in a scheduled manner to address kind of lingering symptoms. And they they can take it 3 to 4 times a day, could do up to 2 vials of that, so 200 milligrams up to 4 times a day. Can also be flexible. They don't need to have that the same dose each instant. So sometimes we tailor this around their GI symptoms. And people have really seemed to respond well to gastrochrome if they have significant GI symptoms. We don't tend to use this in folks who don't report gastrointestinal issues. At times, gastrochrome is in shortage. I think it just doesn't get used that much. And so it may be that the supply is just kind of limited. Doesn't seem to be a particular brand name, but fortunately, most pharmacies seem to be able to acquire it even if they have to order it. But the critical thing is that these ampules or vials need to be diluted. So the gastrochrome is not to be taken neat. It's supposed to be diluted. Usually just a couple ounces of liquid beverage is sufficient. Ketotifen is an oral mast cell stabilizer. It is one of those medicines that needs to be compounded in the US. So we typically have seen this compounded either just through dilution in water or as in capsules, obviously typically plant-based capsules for folks with AGS. The starting dose is a milligram twice a day. I often initiate this at night for up to a week with just the evening dose because it can be fairly sedating. Then we add the morning dose in, get folks up to 1 milligram twice a day. And then based on their symptoms, we can titrate up from there. I I really think about ketotifen as more for people who have some element of mast cell activity that seems to be related to the tick bites in my mind. The most prominent side effect symptom side effects are sedation and weight gain, and it can take a little bit of management, but often folks feel better on ketotifen. I guess the other resource that I think about for people that have some element of mast cell activation that doesn't seem related to MCAS from a different etiology, meaning they seem to develop mast cell activation after the tick bite, as if it's a sort of a post tick bite illness, and they'll have flushing or difficulty tolerating foods, brain fog, fatigue, etc. The other thing that we often ask them to do is take a supplement called quercetin and probably try to push that to about 2,000 milligrams in a day. It's often divided. So you take 1,000 milligrams BID of quercetin. It's a plant-based bioflavonoid that has mast cell stabilizing properties as well. For both patients and providers, I've found alphagalinformation.org to be a reliable source of information and resources. I not uncommonly refer patients here because there are lots of resources that are accumulated at this site and directed for patients, and really kind of walks people through an initial diagnosis, but also living with AGS, as well as some of the other resources shown there. This is the landing page for Pill Clarity, where you can click on Find Products, and they may list things for, say, personal care or other medications that have already been vetted and established to be allergen free. Or you can ask a pharmacist and just say, I need to start my patient on a blood pressure medication, and I would prefer that it be an ACE inhibitor. Can you give me some options within that class that are alpha gal friendly? And in time, you'll get a response, usually a PDF listing various NDC numbers that can then be used to help prescribe something for your patients. It's an invaluable resource, and I don't know of anywhere else that that type of knowledge is available to assist from the medication standpoint, which can be really difficult for some of the more sensitive patients. And even if, as a provider, you're not aware of Pill Clarity, formerly Vegan Med, I can assure you that many patients are. And this is data from Sachin Shah's group showing over 96,000 unique visitors to their website in 2024 and where they were coming from. So people are asking for the expertise in, particularly as it relates to their medications. And Pill Clarity has really kind of filled that void to an extent that I don't think anyone else has. So it's a quite valuable resource. As a bit of a looking forward slide, I will tell you that one of the things we're actively involved in and working on is trying to establish the national seroprevalence of alpha gal IgE. And in conjunction with colleagues at the CDC and elsewhere, we are currently assaying blood donor samples to try to establish the prevalence of alpha gal IgE in various states that represent both high, low, and Lone Star tick territory, as well as others without Lone Star ticks, to have a sense of what might be the the general prevalence of alpha gal IgE. We obviously think there's a fair amount of geographic influence, probably based in a large extent on the presence of Lone Star ticks in certain areas, but perhaps not exclusively for that. So hopefully this study will shed light on that aspect, and we'll have more to say and more to come with this data. So with that, I'll wrap up. I hope this has been helpful as a resource for those of you managing patients with AGS, or those who just needed a deeper dive into the nuts and bolts of alpha gal syndrome. You can see several of the various ways to let me know questions that you'd like to ask. Thanks so much.